Hello, everyone. For those who just joined, thank you so much. This is the YEPC COVID-19 vaccine webinar. We'll be getting started in around 1 to 2 minutes, so just hold tight. All right, hello everyone. Thank you so much for joining. This is the YEPC COVID-19 vaccine webinar. We're really excited to have all of you here today, and we have some amazing guest speakers. We're gonna get started now, but before we start with the presentations, I wanted to give a quick background about YEPC, so you know the organization that is holding this event. So I'm Yusuf Rashid. I'm the president of Youth Emergency Preparedness Council, which is YEPC's expansion. We're a 501c3 nonprofit organization dedicated to preparing the community for disaster preparedness and emergency preparedness. We're divided through student representatives at local high schools throughout the Bay Area, and we're rapidly expanding right now into Newark, Union cities, and other cities close by. So if you are a student or a parent who's interested in joining this organization and helping out with our mission of talking about and educating the community in emergency preparedness, you can visit our website at www.yepc.net and contact us there. So today we have some great guest speakers with us today. I wanted to introduce them really quick and then hand it off for our first presentation. So we have Dr. Omai Garner, who is an associate clinical professor and the director of clinical microbiology at UCLA. We have Ms. Laura Barranco and Ms. Lisa Erickson, who are both part of the Alameda County Public Health Department. We have Dr. Diane Martin, who will be joining us shortly. She's the infectious diseases specialist at Washington Hospital. And finally, we have Commander Matthew Johns, who will be joining us at 4:30 p.m. And he's the regional health administrator for the U.S. Department of Health and Human Services. Dr. Garner, before I hand it off to you, I wanted to give everyone who's watching a quick rundown of what the agenda is going to look like today. So for the first 20 minutes, Dr. Garner will talk about the science behind the vaccine, some clinical trials and his experience at UCLA. After that, Ms. Barranco and Ms. Erickson will talk about their experience at the Alameda County Public Health Department, and also, which I think is really cool, we'll be getting some information about what the COVID-19 plan is for Alameda County schools here. After that, Dr. Diane Martin will talk about what locally is happening for the vaccine rollout from Washington Hospital. And from 4:30 to 4:45, Commander Johns will talk from a federal and national level standpoint about what the vaccine rollout plan is looking like for the whole United States. And then for the last 15 minutes, we'll have the Q&A session. I'm going to hand it off to Ashika and Charita real quick to talk about our Q&A, and then Dr. Garner, you're good to go.
Hi, everyone. So as Yusuf had mentioned, there will be a Q&A session in the last 15 minutes of the webinar. So how this will work a little differently if you are an attendee in the webinar itself or on the YouTube live stream. If you are an attendee, then there will be a Q&A button at the bottom bar of the screen. If you click that, a chat box should open up and you can type your question there. There is a gray text afterward that says your question has been answered live, that means we have noted down the question and we will reference it to the doctors at the end of the presentations in the Q&A section. If you are in the YouTube live, then similarly, you will type your questions into the live chat box and we will pin and unpin the question. That will also mean we have noted down the question and we will reference it later.
All right, thank you, Ashika. Dr. Garner, the Zoom floor is yours.
Excellent. First, I'd like to thank YEPC for inviting me to talk. You know, Having worked in infectious disease diagnostics and the medical school at UCLA and running a clinical laboratory that does testing for infectious disease over the last 10 years, unfortunately, emergency preparedness around infectious disease is becoming common, right? Because if it's not COVID-19, it's a Zika outbreak. If it's not Zika, it's measles. If it's not measles, it's Ebola or maybe COVID-25. So, as this sort of group gets more and more prepared, I'm very excited about the work that you're doing, because not only are you spreading information for the community, you are also encouraging young people to potentially pursue careers this direction. And there are a lot of very exciting careers this direction. So I have the task in the next 20 minutes of telling you all that I possibly can about the vaccine trials, and potential side effects and efficacy of the vaccines. This is challenging. And so I won't be able to touch on all of these things, and I'm going to move relatively rapidly through the course of this. But if you have any questions afterwards, unfortunately, I have to leave a little bit early. I will also take some of those by email. So let's start with the concept of a vaccine. So the idea of a vaccine is really wrapped around an idea called protective immunity. And the way protective immunity works is that when you're infected with some kind of pathogen, whether it's bacteria or virus, your body mounts an immune response. You have immune cells, they make antibodies, and they fight off that particular immune response. Now, what's beautiful about your immune system is that not only can it successfully fight off that pathogen, but it creates a memory, a protective immunity about that particular pathogen, and that's held in antibodies that are circulating in your blood. What this means is that the second time you come into contact with that infection, those antibodies, they take hold of that infection and they fight off that disease before it can even account for any symptoms. This is the idea of protective immunity. Now, what's great about it is that you can't get the same disease twice in most instances. What's bad about it is you have to get the disease in the first place to be able to get protective immunity. And as we all know, you may not survive that first encounter with that particular disease. So the idea in the medical community is, how do you create protective immunity, right? Make these antibodies that are circulating in the body, but don't actually have the person get the disease. This is the concept of a vaccine. And I really can't emphasize, successful vaccines are one of the reasons why we live so long. Successful vaccines are one of the reasons why we've fought off diseases that have killed millions and millions of people, diseases historically like smallpox, like measles. So vaccines are a very successful way at combating especially pandemic diseases that can have effects across the entire globe, like we see for COVID-19. So I want to spend a little bit of time exploring how vaccines are made, because there are a lot of different vaccines, some of which you've heard about, right? There's the new mRNA vaccine. There are protein vaccines. There are vaccines that are really live viruses that are a little bit beat up so they can't cause disease. So I want to kind of cover that and get an understanding of all of these different types of vaccines. So one way to make a vaccine, remember, we're trying to expose the immune system and create protective immunity, but not give the actual disease, is to take, let's say, the virus that causes a disease and beat it up a little bit. That level of beat up virus you can then expose to somebody, and that exposure ramps up the immune system, creates protective immunity, but you don't get the entire disease. So vaccines like the measles vaccine, the mumps vaccine, the vaccine series you take when you're very small, when you're 1 year old, those are live virus vaccines. So that's one way to create a vaccine. Another way to create a vaccine is to just use a small piece of that virus or bacteria, expose that small piece to the immune system, and create protective immunity. Now, the challenge of this is you have to pick the right small piece, right? Because it's not all of the pieces of the virus that actually create the protective immunity. So there's a fair amount of medical research that needs to go into that particular disease, that particular virus, to figure out which one of the small pieces will actually create that protective immunity. And then you can give that small piece, like a protein, give that small protein in the arm, create an immune response just to that protein, and you create protective immunity. You create antibodies throughout the entire body. So then when you contract or you come into contact with the actual disease, you already have protective immunity and you're protected from getting the disease. So hepatitis B. The hepatitis B vaccine is a very common vaccine. This vaccine is actually based on that theory. You give one small protein from that hepatitis B virus, and that protein is able to create that protective immunity locally in your arm, antibodies spread throughout the body, and now you're protected against hepatitis B. So this is the theory on a lot of the vaccines for COVID-19. Let's use a small piece of COVID-19, expose a person to that small piece, and create protective immunity. So the first question is, which piece of COVID-19 do you use? Medical research has shown that the spike protein, and this is something that I'm sure you've heard about in the news, the spike protein is found on the outside of the virus. What the spike protein does is it lets the virus contact a cell and infect that cell. If you're able to block that from happening, you can actually stop the virus from causing disease. So medical research has shown is that if you're able to expose someone just to the spike protein, just to that small amount on the virus, you can actually create that protective immunity. So one of the vaccines that's going to come out is going to be a spike protein vaccine. Now, what's interesting is the mRNA vaccine, and this is the new vaccine. The technology is not new. Technology using mRNA has been around for a while, but this is the first time a vaccine has been made out of that. Uses the same theory. We need to make the spike protein. One way to make the spike protein is just to inject the spike protein into the arm. But another way to make the spike protein is to actually look at the genetic code for that spike protein and get the body to make that protein itself. So viruses are composed of two different pieces. You have the proteins on the outside and the inside of the virus, and these are the things that actually cause disease. And then you have the genetic code for the virus. This is inside the virus, and this is called RNA for COVID-19. All of the RNA of the virus, if that's inside a cell, will teach that cell how to make new virus. But if you just use the RNA code just for the spike protein, it only accounts for 10% of the overall RNA of the virus. And you inject that RNA itself, this mRNA, into the arm, what happens is the cells that are there, it's going to take up that mRNA. What happens is it reads it, and it's the genetic code for the spike protein. So the cells in the arm now have the genetic code just for the spike protein. They start to make spike protein. Now we have spike protein locally made, and it's just like a protein vaccine. Right now, the immune system recognizes that spike protein that's there, creates an immune response just to that protein, makes antibodies, and now you have protective immunity versus COVID-19. So this is a wonderful idea. One of the advantages of using mRNA as opposed to using proteins is you can actually make that little piece of genetic code much faster. You can make it faster, and then once you make it faster, you have a vaccine product that can actually be made versus just making the protein. Making the protein is actually more difficult. So in that setting, one advantage and one reason why this happens so quickly is because it's an mRNA vaccine. So again, as a review, the mRNA vaccine, the goal is to make protective immunity. You want to expose the immune system just to the spike protein. The way the mRNA vaccine does that is that mRNA is just the genetic code taken from the virus of the spike protein itself. It's the instructions to make the spike protein in the cell. You inject that into the arm, it takes up that mRNA, and those cells make spike protein. Presents that to the immune system sees that, makes antibodies to it, and now you have protective immunity. So this is wonderful. And the science behind it was fantastic, and it looked like it worked well functionally to create that protective immunity. But the next question is, does it work? Right? Because you can make a vaccine, but if the vaccine doesn't actually work, if the vaccine isn't actually protective, then you haven't made anything successful. So in order to do that, you have to run what are called clinical trials. And there are 4 total phases to a clinical trial for a vaccine, and we're going to focus in on the first 3 phases. So you've made your mRNA vaccine, it's going to make spike protein in the cells, and it's going to produce that protective immunity response. First part of a clinical trial is take a group of people, small group of people, 50, 100, inject them with that mRNA vaccine, wait a certain amount of time, and measure the antibodies. Measure for protective immunity, because you need to have a strong immune response. So draw a little bit of blood out of the person, and you can measure those antibodies that are there. What's interesting in doing that is that after the first 2 to 3 weeks, everybody who had the mRNA vaccine actually produced antibodies in these early trials. That was wonderful news. The second question really you have to ask then is, are those antibodies that are made to that spike protein effective at stopping the virus from infecting? So this is where science gets super cool, because what you end up doing is you have live virus in a dish, and that virus can infect those cells. Then you take the antibody from the person that was made from that mRNA vaccine, and you put it in the dish. And you're asking, will that antibody stop that virus from killing those cells? That's protective immunity. Now you know you have a vaccine product that has made antibodies successfully in those people. Those were the phase 1 and phase 2 trials associated with this particular mRNA vaccine, both Moderna and Pfizer. And there are 2 different versions of the mRNA vaccine. This went fantastically well. People that were vaccinated produced an antibody response, and they were neutralizing. That's the word that we use for an antibody that will stop a virus from actually infecting cells. They made neutralizing antibody, and they made it most effectively after the second dose of the vaccine. So this is why these questions come up. Why is there only 1 dose, or why is there 1 dose followed by 2 doses? It's really this measurement of protective immunity that then proves that. So great. We've moved into this wonderful situation where we have a vaccine, it's an mRNA vaccine, it makes the spike protein, and you make protective antibodies in like 50 or 100 people. Now you have to ask the big question. Does the vaccine actually prevent disease? Because this is the thing that matters, right? So now you enter what's called the phase 3 of a vaccine trial, and this is the big phase. So what you end up doing is you take 40,000 people, 20,000 of them you give the vaccine to, 20,000 of them, they get what's called a placebo. That word placebo means just saline, so there's no vaccine product in there. You're blinded. You don't know who's in which particular group. And then you let those 40,000 people go out into the world. The reason why you take so many, there were 130 different sites across the country that enrolled those patients, is because you need people to catch COVID. Now, we don't run trials where we force people to catch disease, right? So what you end up doing in the trial is you take those 40,000 people and you say, okay, live your lives. Some people are going to be very careful. Like me, I don't go anywhere without my mask. The only people I see without my mask are my wife and my child, and nobody else. So if I'm in a vaccine trial, it's hard for me to catch COVID. You need a certain number of people to catch COVID in that 40,000 people, because it's the only way you determine whether or not the vaccine is protective. So what happened? Now, you remember, COVID has been out of control in the United States. And so there are a lot of people that are catching it. So a lot of people in the vaccine trial caught COVID. Almost every single person who caught COVID was in the placebo arm, meaning it was the group that did not get the vaccine. So you've heard these numbers like this vaccine is 95% effective. This vaccine is 94% effective. This is where they're getting these numbers from. Out of the 40,000 people in the trial, something like 168 caught COVID. 160 of them were in the non-vaccinated arm, and only 8 were in the vaccinated arm. So you can take that as a number and say, well, of all of the people that got COVID, 95% of them were in the non-vaccinated arm. So you have a vaccine that was 95% efficacious or effective at stopping COVID, because the exposure rate of COVID amongst all of those people is equalized because you have so many people. So again, they've run these fantastically successful clinical trials. They were not expecting the vaccine to be that effective. A great number would have been like 60% effective, 70% effective. But it's really this new vaccine product, this mRNA vaccine, that created so much protective immunity, again, after the second dose, that people didn't get COVID at all, even though they were exposed to COVID. So that was really the data that the FDA took in. That's the governing body that decides whether or not vaccines are approved, to look at to say, wow, this is a great vaccine. We can release this for clinical use. Now, efficacy, does the vaccine work as one arm? But the other arm is it safe, right? It's new technology, or at least it's new technology from a vaccine perspective. How do we know it's safe? So the way that you look at safety from a vaccine product is that you look at those two arms and you ask everybody, the people who got the vaccine, 20,000 people, and the people who didn't get the vaccine, 20,000 people. And remember, they don't know what group they're in. What are your symptoms? Does your arm hurt? Are you experiencing nausea? Are you having headaches? All of the things. And then they compare the symptoms in the vaccine arm to the non-vaccine arm. And so what were the common symptoms? The common symptoms for the vaccine arm were local pain. Now, anyone who's had a flu shot knows it hurts a little bit. Why? You're getting an immune response right in that area. Immune cells are coming in, they're reacting to the proteins that are being made, making that general protective immunity, so there's some inflammation. There's some pain that can occur in that small area. Very common. What was far less common were things like headache and body aches, feeling tired. These were also symptoms that were found in the vaccine arm. And in that setting, you know, the numbers were somewhere between 10 to 15% of people had that level of symptoms. So again, doing pretty good. Now, there were other side effects: severe headaches, nausea, diarrhea, things where you're like, oh, that's really bad. But what's interesting is that it was the same in the vaccine arm versus the non-vaccinated arm. So those symptoms were found on both sides. Your brain can do a lot of things to your body. Worry, stress, panic can do a lot of things to your body and manifest as particular symptoms. So they were able to not associate those with the vaccines because they saw them in both arms. So this was really high quality safety data in the very short term, right? And they were tracking people for about, the 3-month tracking has already been done. The 6-month tracking is occurring now for all the people that were in those vaccine trials. So they're continuing to try and find out whether or not people will have longer term side effects associated with the vaccine. Now, what's nice is vaccines are not new to us from a medical community perspective. And we have a lot of vaccines that are available. So the formulations behind those vaccines, we understand safety, we understand potentially what populations can have long-term consequences. And that is what gives us confidence about the safety of this current vaccine product. Now, in my last couple of minutes, I want to talk about people who weren't in the vaccine trials. So the people who were in the trials, adults over the age of 16 for Pfizer, adults over the age of 18 for Moderna, and they took a lot of people over the age of 55. Why? Because that's where COVID-19 is the worst, right? Is in people over the age of 55. So a lot of them were included in that clinical trial. Who wasn't included? People who are pregnant, children between the ages of 0 and 16, people who have autoimmune disease. A lot of different people were not included in the trial. So that's why I said these clinical trials have 4 phases, because once there's approval, they continue to do studies. So there are trials going on for children right now to see if we can get approval of this vaccine for people either under 16 for Pfizer or under 18 for Moderna. So there are a lot more science to do as we roll out this particular vaccine product. So I'm running up against my time. I think I'm going to stop there so we can save time for the rest of our presenters. I want to thank you for your time. I hope you found it informative, and I look forward to hearing about any questions you may have.
Thank you very much, Dr. Garner. That was a great breakdown of the vaccine. I'm going to switch back to gallery view so everyone can see all of us. Thank you, Dr. Garner. That was great. And
for sure.
Share your email with the attendees afterwards in case they have any questions for you. All right, I'm going to hand it off to Ms. Lauren Barranco and Ms. Lisa Erickson now. Would you guys like to share screen for your slides or anything?
Please, if that's all right. Try
yes,
it.
There we
go.
go.
Sharing, and am I sharing full screen?
Yep.
Yes, great. Okay, thank you so much for inviting us and having us. Maybe we can each introduce ourselves, and then I go first, and then Lisa will have her portion. So my name is Lauren Barranco. I work with the Alameda County Public Health Department, as mentioned in Yusuf's intro, and many of us in the Public Health Department have been deployed during COVID, because obviously that is our huge priority. And I am working with a community advisory group that we have around vaccine planning, which I'll talk about in a bit. But I wanted to talk to you a little bit about Alameda County's vaccine rollout and the different ways in which we're engaging. So you'll see on this front page here, a covax@acgov.org is an inbox that we set up. If you have questions about vaccine, that's a great resource. And then I'll also point you toward our website as well. And of course, we'll provide my information, but faster information here. So I wanted to talk a little bit about the vaccine planning. So we wanted to lead with our COVID vaccine or COVAX principles and values. We intend to provide transparent and accurate information to help people make vaccine decisions. The vaccine is a choice, despite being, obviously we recommend it, but it is an individual choice. We want to lead with equity and with data based on race, ethnicity, geography, socioeconomic factors, critical populations, as we know that COVID has had disproportionate impacts on specific income groups, zip codes, and races. We want to ensure safe and equitable distribution, and then leverage all of the venues and partners we possibly can for broad distribution. So in terms of our local plan, we have three main sort of focus areas, but we're a big, well, not a big, we're a small but mighty team who are working on the vaccine. We really have three kind of verticals of how we're trying to engage around it. We have a community advisory group, which I think I told you I'm staffing. We have regular meetings with folks in our healthcare delivery systems. So we're convening our hospitals and our clinics to work on how they can support us in not only getting their own folks vaccinated, but getting the community vaccinated. And then immunization logistics. It takes refrigeration and freezing. It takes technology. It takes a lot of logistics to set up a vaccination site. And we want to be really intentional about where they happen, make sure it's accessible and safe, and having enough staff members to administer vaccine. So this is our vaccine prioritization framework. And the vaccine prioritization is really set at the federal level by the CDC, and then the state of California really determines it on a more intentional level for the state. So we're pretty beholden to the state's prioritization of different populations, and where we have a little bit of wiggle room is in how we sort of finish one tier or finish one phase and move to the next and start inviting people in. And we really want equity to be at the forefront of all this. At the same time, we recognize that urgency is really of the essence. So right now we're finishing up phase 1A. And so phase 1A has been our healthcare workers, and the state broke them into separate tiers. Hospitals first, tier 2 was more like community health workers, tier 3, folks like dentists, pharmacy staff. And pretty prescriptive of having to go one, tier 2, tier 3. But again, with the urgency, the state changes on sort of an hourly or daily basis where these priorities are and the order in which they go and how strictly we have to follow them in order. So we still have some major groups that we need to vaccinate. We're hoping to vaccinate IHSS and home healthcare workers in the upcoming week or two. There are about 26,000 of them throughout the county. So we're starting to get into really big populations where we need to work on our messaging to folks and then set up sites to be able to hold that type of volume. So what we are planning for next is phase 1B. And actually, just even in the last few hours, the state made a change where they were prioritizing folks 75 plus in tier 1 and then folks 65 plus in tier 2. And they just collapsed the two of them a few hours ago. So it looks like folks 65 plus will get to go in phase 1B tier 1. But again, we're really trying to get ramped up, hopefully by February, hopefully by early February, to start providing vaccinations to folks in phase 1B tier 1, which include our folks in education and childcare and food services and folks over the age of 65. So then you'll see phase 1C gets into more essential workers. Phase 2 is finally when we're getting to folks under the age of 50 who have underlying health conditions. And then, as was mentioned in the last presentation, the trials have not included children for vaccines. And so it will be later down the line when folks who are under 18 or under 16 will be in our kind of queue for vaccination. And we hope to have a lot more data by then. So next, and all of this is on our website. So next, just getting a little more granular, just wanted to show you kind of within the phases, where the state has gotten us to get a little more specific on who is defined in some of these different categories. And so if there's anything to sort of highlight, I wanted to show I made the change that the state makes these changes on an hourly basis. So I know there's a lot of requests for us to get as much up-to-date information out to the community as possible. And we're working to keep up with the changes that are made. But we are really looking forward to starting to vaccinate large swaths of the community who fit into some of these big categories as soon as we can. And all of this, again, is dependent on staffing and on the number of vaccines that we receive from the state each week, which varies. So just to give you an idea of some of the numbers, and this is from yesterday, phase 1A, which were all those healthcare workers, we approximated the number of folks in that category at a little under 150,000. So far, we've received 53,000 doses, first doses, and 32,350 second doses, because there are some healthcare workers who are already on their second dose of the vaccine. You'll notice it says excluding Berkeley. The city of Berkeley has its own public health department. So they do their own vaccinations and their own information giving. You'll notice that we've given a number of the vaccines directly to hospitals to vaccinate their staff, other healthcare entities, and then we as the county received 27,000, and we have administered about 7,500 of those, and that next 20,000 that we have safe in storage is preparing us for this next big group, or these next big groups that we need to vaccinate in the upcoming weeks. Like I mentioned, in-home supportive services, or IHSS workers, there are about 26,000 of those in the county who we need to vaccinate next. Just wanted to list some of the things that go into our planning for how we vaccinate, how much is available, determining how many people are in each category. We're trying to get our best estimates of how many people are in healthcare, how many people are in our education system, how many informal childcare providers we even have. And so some of the numbers are easy to get, and some of these numbers really require data digging and really intentional partnership with community partners and institutions who can help share with us the scope of who's coming up next. Other things, we have to figure out how to reach eligible folks. We have our website, but not everybody is going to that. Some people respond to text message, some people respond to email, some people are homebound and need somebody in person to let them know when it's their turn and how to get a vaccine. So there's a big infrastructure lift on our behalf. And then also a major critical issue right now is staffing. We are still in an incredible COVID surge, and our hospitals are overwhelmed. And so having qualified vaccinators to be able to administer vaccine has been a real challenge. And we're working with the state and with our local relationships and resources to try to really beef up that work, or sort of that volunteer force. We also have technology considerations, because all the information on immunization needs to go into a registry so that folks know when they need to come back for their second one, and so that we have a record of who's been immunized. And then we have to figure out where to set up a pod in which we can invite, hundreds or even thousands of people in a day. How do I get my vaccine? So right now, we have been, because we're only doing healthcare workers, most folks have been getting their vaccine either through their employer or through points of distribution called pods. And the county has 2 of them that are open as of this week. They're open during limited hours on a few days, but they are places in which people who are eligible can make an appointment and go get vaccinated. Hopefully, and this is still being worked out with some of our major providers like Kaiser and Sutter, and a lot of our local clinics, hopefully many folks will be able to get their vaccines through their healthcare providers. And this will be as we continue to have enough vaccines. So community clinics, urgent care, hospitals, and doctors' offices are things we hope will be in the pike, along with mass vaccination events, which we're considering doing. I'm sure you've seen in the news that Dodger Stadium is going to be a vaccination site. And so that's something that we are trying to scope out as quickly as we can here. And then how will you know it's your turn? Depending on what group you're in and which group kind of comes first, you may hear via your employer, you may hear through your medical insurance. Hopefully we're going to do our best, or we will continue to try to do our best around public messaging and communications and community groups. And if anybody wants to get a little more information, we just put something on our website, which is at acgov.org, where you can sign up to receive notifications about the vaccine. So I'll leave that later. And then speaking of communications, I just briefly wanted to talk about how we're getting information out and how we're messaging people. We have a communications plan that is, centered on our website, but we've been working to get information out as best as we can through media. Our social media, we've really been working to be intentional about increasing the content there and increasing our reach. We have a Nextdoor, we have a Twitter, a Facebook, and an Instagram. So if you can look for Alameda County Healthcare Services Agency, or if you can look for our handle, which is Dare to Be Well, and it's awkward, but it's cute, and it's right here. I'll leave it for you later. We'd really love anything that you're willing to reshare, to share with us, because we're really hoping to reach people in as many different ways as possible. And then in terms of community engagement and outreach, opportunities like this are fantastic because we get to speak to a specific group of folks who already are being called to a space by people they know and trust. And so we're really hopeful that you will continue to be, messengers who get in dialogue with the people in your communities as well, and feed back information to us while we just continue discussions on how vaccine is affecting our community. We're working to do town halls. We also have this community advisory group to which I alluded, and we're working with a number of nonprofits who are in our network to try to amplify messaging. Also on our website, if you're interested in data, we have our dashboard. So we have the numbers on testing, we have numbers on case rates, race, zip code, population, city, and so it really can be interesting, helpful information, and it really shows us how dramatic our spike has been in the last couple of months. So finally, as I mentioned, we're really trying to continue to expand our network. So thank you again for having us here with you for this. And I think I'm next turning it over to my colleague, Lisa.
Hi, everybody. Hopefully you can hear me okay. I'm just going to do a brief overview of some of our school guidance and just kind of the reopening process, and talk a little bit about reopening for all of you. So we're going to pivot a little bit from vaccines, and this is going to be a little different for the next few slides. Oh, thanks, Lauren. I have to tell you when to turn the slides. So before we get into school reopening, I thought it would be important to just do a quick overview of the California's Blueprint for a Safer Economy, which is how, this is what they use in order to open different sectors within our state. And so right now, this shows you a map of California and the different tiers. There's 3 tiers. There's purple, red, and orange. Right now we're in purple. Most counties are in purple, as you can see, including Alameda County. And so this is basically, this means widespread of COVID-19. And this, I believe this is updated fairly regularly on the state's website. So you can find that there, and you can, you can actually search by county on the website. Next slide, please. And so this is data specific to Alameda County. And as you can see, so if you look at the tier 1 where it says widespread, and if you move to tier 2, it'll show you the data or the numbers that you need to meet in order to move into tier 2. And when you're moving into tier 2, that's when schools, most schools, all schools are really allowed to open. So right now we're in purple. And so that's limiting our ability to open schools right now. But I am going to talk about a new state program that's going to be launched soon to help schools open even in the purple tier. And so as you can see, our cases per day, our adjusted case rate is 41.7. And in order to move to tier 2, you would need between 427. So it's a huge, we need to decrease our cases a lot in order to move into the next tier. And just a little bit about these different numbers. The first one is our adjusted case rate. That means that the state takes into consideration how many tests we're doing. So since we're doing so much testing, they'll take our case rate and adjust it and make it a little bit lower. And then this is the overall positivity rate. So this is the rate of how many people are testing positive, who are going and getting tests. And then lastly, this the lowest HPI. This is the health. Oh gosh, now I'm forgetting the acronym. Lauren, do you know the acronym for this one again? I completely forgot.
I don't have. I stands for index. Yeah, and you can explain it.
Oh, I know what it is. It's the Healthy Places Index. Okay, so this is this is interesting because they really look at the different neighborhoods within our county. So basically the neighborhoods that aren't really impacted by COVID aren't able to kind of bring up the other neighborhoods. So they really want to see that in the neighborhoods that have the lowest health outcomes are doing okay as far as COVID. And right now you can see that we're not really, it's pretty high in those HPI neighborhoods, in the neighborhoods that have lower health outcomes. It's at 13.3%. All right, so next slide. So just I guess it was December 30th, the governor launched his new Safe Schools for All plan. I'm not going to go into it in too much detail, but you should know that there is this plan, and there's 4 pillars of this plan. The first one is funding. This obviously needs to get approved by the legislature, but what he's proposing is a $2 billion, it's like extra money basically for schools it's an incentive for schools to reopen in February. And then I think he has another incentive for also for March. So it's $2 billion, and this would actually go toward individual students. So it'd be by student is how it would work. There's also going to be more oversight and assistance at the state level, more state help with safety and mitigation for contact tracing and vaccines and everything that's been happening basically since March, just more attention toward that. And then lastly, there's going to be a state dashboard that's going to talk about which schools are open and what does the data look like for school reopening and transmission. So you'll be able to look on that dashboard to see what the cases are like in particular, I believe, districts across the state. Next slide, please. So as I mentioned, we're in the purple tier right now, so we're not able to open schools. However, the state has come out with this proposal that if they follow certain criteria, they can actually open in the purple tier. And so what they would need to do is submit a COVID safety plan, and they need to work with us, with our public health department, to review those plans. And you need to make sure that the case rate is 28 cases per 100,000 or less, for at least 5 consecutive days. And as you just saw that on that first slide, we're in the 40s range now. So we're not quite there yet, but we're hopefully our cases will start to go down and we can start to open schools while we're in the purple tier. And we're learning a lot more about this from the state. They haven't even released their updated guidance yet this week. Hopefully by next week, we'll have more details. But just wanted to give you all a heads up that this is all happening right now. Next slide, please. So now I'm just going to talk a little bit about the guidance, and what we call it in public health is guidance. So this is like COVID-19 health and safety guidance for schools that want to reopen. There's a lot in there. This is just going to be a very high level of like 4 areas that schools need to focus on in order to open their schools. And again, there might be changes because the state is releasing new guidance soon.
Sorry, Lisa, you're fading in and out a little bit sometimes.
Oh, okay. Thanks for telling me.
Stay on your mic.
If I sit closer, that might be better.
Yes, no, it's great. Mm-hmm.
Okay, thanks. So the first concept is cohorts. And basically, and you might have heard people call these bubbles or pods, but in essence, what it means is that kids or youth should stay within one group as much as possible. And so they don't want to have a lot of mixing. So if you're going to school, you need to stay within your cohort or your bubble. And this is obviously a lot harder. Anyway, so these are the cohort. It's harder to do in high school, but there are ways to do it. And so that's what I think a lot of schools are struggling with right now, is just figuring out how to bring kids back in these stable cohorts. Next slide. And the cohort should remain the same for at least 4 weeks. So you really want to keep those cohort stables for as long as possible. Next slide. And also, like I mentioned, not moving around a lot. So ideally you would have the same teachers, the same kids. Again, just sticking with the same bubbles in your school. Next slide, please. And another component of the safe opening, this is kind of a self-explanatory one that I'm sure everyone's heard of already, but all students and staff are required to wear face coverings. So kindergarten and up, and all the staff, must wear face coverings when they're back at school. Next slide, please. And physical distancing. So trying to keep students and staff to physical distance as much as possible in the school. This is sometimes difficult, especially with little kids. It's going to be harder to do. But if you're doing the face covering and you're also doing the cohorts, then the physical distancing may not be quite, you don't have to always be 6 feet apart if you're doing those other measures. The way that these work is that they need to all kind of work together. And if everything is happening together, sometimes you can kind of be flexible in between these different strategies. Next slide, please. And the last, this is the last kind of tenet or pillar of this, of the reopening guidance for schools, is health screening. Everybody, staff and students, all must do health screening before they come back to school, before they come on campus. And this is a daily thing that everybody must do. And it includes 4 components. First is the exposure check, which basically means asking if anyone has been exposed to someone with COVID. And they ask about COVID symptoms, and they also do a visual check and a temperature check, which is optional for K through 12 schools. Next slide. I think I already mentioned this, but yes, students and families are required to do this screening, and they can do it at home before entering the building. And any sort of symptom that anyone is experiencing, there's a long list of symptoms. It could be a runny nose or a headache. Any of these symptoms, you should be sent home or you should stay home if you have a symptom. Next slide.
I believe that is it.
Oh, okay, thanks. I think we're right on time.
Perfect.
So all right, thank you, Ms. Erickson. Let me go back to gallery view. Thank you so much, Ms. Erickson and Ms. Barranco. I'll now hand it off to Dr. Martin. And Dr. Martin, we do have your slides. So Hirsch will be sharing your slides, and then we should be good to go for your presentation. Dr. Martin, I believe you're on mute.
Better?
Now we can hear you. Thank you.
Okay, thanks. So just wanted to take the opportunity to thank you guys for organizing this so that we can explain what Washington Hospital is doing. And a lot of this is in coordination with the county. So what Lauren had also outlined for you is what Washington Hospital is following in general. So next slide. So currently, as Lauren mentioned, we're in phase 1A. So Washington Hospital is currently vaccinating all of their healthcare personnel. So that includes the nurses that provide care, the ER, the intensive care unit, as well as our support staff, which is pharmacy, environmental services, and all of our, even our IT people, so that they are all vaccinated. Because for a lot of us, those are very essential workers that we could not do without. The hospital wants to also help with the vaccination once we roll out into the other tiers. And again, this will be with the guidance of Alameda County Public Health as they activate the other phases. And Lauren outlined those very nicely for you. So I won't go into those in any more detail. Next slide. So the vaccine we think is extremely safe. I've gotten both of the doses. We've vaccinated almost 2,000 of our workers at Washington Hospital, and to date we have not had any adverse reactions. We are vaccinating in a designated area. We have a crash cart available if we should need it. We have a gurney in case we should need it, and it's one floor above the ER should we need it. But so far, I guess knock on wood, we have not needed it. So we feel that it is very, very safe for all the healthcare workers that we have provided it to. Effectiveness, as you may be aware, we think it is extremely effective. When they look at the antibody response, even after first dose, it's extremely high. Now, how long that's going to be maintained is difficult to say. Some people say months, some people say up to 6 months. At this point, I think it's to be determined. Reactions that we look for are the ones that we've discussed before: fever, arm swelling, nausea, vomiting, some diarrhea. And then again, we do worry about anaphylactic reaction. So a person who has had a vaccine before where they became very faint, low blood pressure, and had to be assisted, dizziness, that kind of thing. We have not seen that, but it has been reported. So those are the main reactions that we're looking for. Currently, the number of doses for both the Moderna and the Pfizer is 2 doses each. The Johnson & Johnson is made somewhat differently, and it's a single dose, but that one has not yet been FDA approved. We are only doing the Moderna and the Pfizer. Next slide. So we have recommended and encouraged that the vaccine be provided to as many people as possible. We are trying to follow the Alameda County guidelines for when we do roll it out. We would really like to reach out to the underserved communities, because that is who makes up the population of our county and our district. And we'd like to make sure that those people get the information and get as much access to coming to get the vaccine as possible. So we're working directly with the county. We have a team locally in our hospital that's working on this in conjunction with the county, and they meet almost every couple of days trying to figure out how we are going to mesh with the county to provide the vaccine to the community as soon as possible. Because we feel that the vaccination is critical to ending this pandemic. I think it is key. This is what we need to do. We need to reach out, and I'm so grateful that you've provided this vehicle for getting information out there. I think a lot of people have fears, have concerns. I mean, there's a lot of stuff on the internet, pro and cons, some misleading and not correct. But I think if we have the opportunity for discussion, I think we can improve the way that people see this. And then within your own pods, reach out to your family and your friends and explain to them how you feel about it. And they have questions, you have enough information now to sort of reach out to them. So currently, the only 2 groups that we are not vaccinating are children, and that's simply because it's not been studied. There have been some where they did get vaccinated but not studied, so it probably is safe, but not been studied. The other group is people that have anaphylactic reactions to other vaccines or other ingested products, shellfish, etc. So we think those 2 should not be vaccinated. Probably in future, that might be something that can be done with a different type of vaccine, like the Johnson & Johnson is made quite differently. Next slide. So ongoing safety, we think that this vaccine is extremely safe, and we do think that this is key to getting most of our community vaccinated, because obviously the more that are vaccinated, the safer it's going to be to try to go back into congregate settings like we're so used to doing. But until then, I'll leave you with the 4 W's. Next slide. So wear the mask. It's mandatory. It makes a huge difference. Wash your hands often as you possibly can, and watch your distance. The last slide has a couple of website resources that are available that you're probably already familiar with, but in case people have questions, it's a very good resource. So the next slide has that. So our Washington Hospital website has it, Alameda County, and lastly is CDC. All of these are outstanding and excellent resources for looking at more information. So again, thank you for hosting this. I'm very appreciative to what you've done.
Thank you so much, Dr. Martin. Let me go back to gallery view. Thanks for that presentation from the Washington Hospital perspective. I'll now hand it off to Commander Matthew Johns. Commander Johns, can you hear us?
I can, Yusuf. Can you hear me okay?
Yes. Would you mind turning on your video if you have that?
Yep, you bet.
Great. Thank you. Zoom floor is now yours if you would like to go with the presentation, Commander Johns.
Well, thank you, Yusuf, and thank you to my fellow panelists, Dr. Martin and others, for the wonderful presentation. Yeah, let me start. Again, thank you again, Yusuf, to you and your colleagues and your counterparts there as part of this forum for the opportunity to chat with you a little bit about some of what we're doing here in Region 9. I'm Commander Matthew Johns. I'm the Regional Health Administrator for the U.S. Department of Health and Human Services based in San Francisco. As a Regional Health Administrator, I serve as the Senior Public Health and Medical Lead for the federal government across Region 9, which is fairly extensive. It's Arizona, Nevada, California, Hawaii, and then all of our Pacific jurisdictions as well, which includes the 3 territories, Guam, American Samoa, and the Commonwealth of the Northern Marianas Islands, or Saipan. In addition to that, we also have 3 freely associated states, territories that are independent countries, the Federated States of Micronesia, Republic of the Marshall Islands, and the Republic of Palau. So our region here in Region 9 is extremely diverse. We cover 9 time zones and have a wide variety of diversity, as you can imagine, with all of what I just mentioned. And I think the latest statistic I heard was there are over 120 different language requirement needs just for LA County schools alone. And so you can imagine the diversity of the broad region that we have here in Region 9 beyond just LA County schools. It goes well beyond that. And so anyways, I just by way of background, that's a little bit of what we're talking about in terms of some of the challenges and all of the complexities involved in this vaccine campaign here for the wider U.S. government, and so specifically some of the work that we're doing out of the regional office, which is I know how we were linked up, Yusuf. So I wanted to talk a little bit about some of where we were with where we are with some of the planning activities and the efforts underway. I think you've probably heard from the other panelists some of what has led up to where we are now in terms of the planning initiatives and the plans through the different immunization task forces and the immunization working groups and the immunization project officers who do incredible work day to day to push out, mostly from CDC, push out really important routine childhood vaccines, and every year push out incredibly important seasonal influenza vaccines to a wide variety of different distribution networks, including retail pharmacists and small level single provider doctors' offices and all the way up to larger universities and others. So and of course health departments, no question. And so they really the project officers really took the lead on getting us to where we are now in terms of the planning that's been required to get this really unprecedented effort underway. And as many of you have probably seen, it is a very incredibly complex. We have 2 products in the pipeline, right? 2 products out on the market right now that are moving forward with some rather challenging logistics and requirements, both temperature and sensitive to vibrations and movements and storage and obviously all of the other pieces of logistics which are important, some of which you've probably already heard about. And then the one thing that as the senior public health person in this region that I often like to discuss with folks, and I think this fits squarely into this overall kind of idea of preparedness, but also has links in with response and also recovery. There's been a lot of discussion on what recovery looks like in the longer term from a post-COVID. What's the new reality look like post-COVID for local health departments, for the medical establishments, health systems, in terms of overall preparedness for what potentially the next wave of COVID or the next pandemic looks like. And so, these are conversations that we're having across certainly the federal interagency, but also expanding out to academic partners, to governmental organizations, to volunteer organizations, to talk a little bit about this idea of actually really utilizing the energy and the efforts underway right now with not just the response to COVID, the acute response and all of the efforts that go into that, to the actual burden of disease, but then also all of these efforts that are going into the vaccine planning and vaccine distribution, to really start to capture these needs around longer term infrastructure development for local health departments, and really start building in my mind, the most important capacity, which is human resources capacity, which is hiring people and getting these health departments back to where they need to be in terms of staffing and funding. Ever since really 2001, and perhaps even before that, 2001 was obviously 9/11 and the anthrax attacks. We've had this smattering of what are called supplemental appropriations. They're usually disease specific. So anthrax came with a little bit of money, and H1N1 came with supplemental appropriations with funding focused on influenza. Zika virus, SARS, each time, Ebola, each time these new diseases come onto the radar, they all kind of follow with this usually fairly constrained amount of money that comes from the federal government to really focus almost squarely on that disease, or at least the infrastructure around that disease. And I think that finally some of the conversations that are taking place right now around preparedness more broadly and around infrastructure development, and certainly will be better informed by what we're seeing right now with the vaccine distribution, is that getting away from this supplement to supplement of appropriations, and getting more into this idea of actually core funding for the public health infrastructure in this country, and try to re-empower these rather beleaguered health departments that are out there that are bearing the brunt of a lot of what we're seeing right now from the actual acute response to the virus, but also the vaccine piece. So I think that, in terms of the overarching theme, I'll talk a little bit about kind of where things are with some of the different vaccine efforts. But that's kind of the larger picture right now, is being able to kind of leverage all of these activities and this energy behind all of this to be able to kind of dovetail it into a longer term meaningful capacity building efforts, and look at what the next 3 to 5 years looks like for health system strengthening and health department development. And again, this longer term capacity building focused on people. And hiring people in the right positions, and hiring them behind appropriations that actually are focused more on public health systems and less on public health threats. So why don't I talk a little bit? I know that I have a little bit of a constrained time, so I'll try to keep it short. I'll talk a little bit about kind of where things are in Region 9, and again, I kind of laid out where the complexities of our region, and I wanted to talk with you all a little bit about some of what we've learned throughout these kind of initial phases of this vaccine rollout. And one caveat here: I'm not part of Operation Warp Speed. I'm the senior HHS person. Operation Warp Speed is a partnership between CDC and the Department of Defense, and it's run at the national level. It's a national level initiative. We certainly work closely with Operation Warp Speed and try to, where possible, provide what we think is meaningful inputs into how best to kind of meet the needs of this very unique region. And we've learned some lessons throughout the early phases of this pandemic, to include everything from a nationwide shortage of swabs, a nationwide shortage of viral transport medium, a national shortage of laboratory reagents and diagnostic tools, and once those do become available, how to get those out to the furthest reaches of our region. So we've been trying to very much inform this vaccine distribution profile for our region as Operation Warp Speed kind of moves forward on distribution. And again, the foundation to this are those plans that I mentioned earlier that were put together by the immunization project officers. And so, so as part of that, I think you've probably heard about some of the different phases involved in the plans underway at the state level. We have some kind of county level initiatives too. Certainly LA County has its own kind of focused effort in LA. But really the phases and the structures and the plans really come from the state plans. And so, a lot of effort right now on receiving the vaccine, storing the vaccine, and really pushing it out as much as possible into arms. And we're seeing that that's a challenge. And again, this goes back to some of what I just talked about in terms of, the lack of infrastructure and some of the challenges that are in place to actually do some of these kind of what most people view as core public health functions. These are kind of core, day-to-day public health functions, but we're talking about something with a very, very tight timeline. We're talking about products with very, very specific requirements and some limitations on the viability of those products and how they go out and how they're managed. And so the timelines are tight and the distribution networks are complex. And so, as we work through phase 1 and phase 1A and phase 1B and phase 1C and start to look at moving from what was very, very, for the most part, standardized and well-defined for phase 1A, which is focusing on healthcare staff, residents of long-term care facilities, skilled nursing facilities, residents and staff, and then some others. The aperture is starting to widen a little bit now as jurisdictions are looking at phase 1B and talking a little bit about, these decisions. I tell people often, public health is a lot like politics. With politics, as they say, everything's local, right? Everything's local with politics. Well, public health is very much the same way. And so the decision making going on right now, I think at the local level is important. And I would say that some of the calculus around what are the priorities for any given county may be different across a state, as we know. How folks are defining priority groups within that phase 1B or beyond might be a little bit different. And some of that variability is challenged by really a kind of a limited supply right now, which we hope in the coming weeks here will be remedied to some extent in terms of getting more product out, which makes that prioritization and the decision making around that a little bit easier. So, and so that's kind of where we are now in terms of this kind of variability, but also a little bit more of a constricted view of where things are, and the conversation that we're having certainly from across the U.S. government and in partnership with our states and our partners at, again, the most local level, is what does phase 2 look like? And so phase 2 is where we really start to think about big, large scale mass vaccination, what's called a pod model, points of distribution model. And what does the federal support look like for that at the most local level? And that could take on a few different it could look a little different in each conversation that we've had, depending on the county that wants to do it. Certainly a mass vaccination campaign in LA would be very different than what it might look like in Reno, Nevada, or Scottsdale, Arizona, or Honolulu, Hawaii. But we're starting to work through that a little bit. Again, thinking a lot of the phase 1 activities that we've talked about really, again, are local decision making on how to prioritize those. Conversations are starting to be had on whether that includes grocery store workers or teachers, or again, it's widening that aperture, as I mentioned, which I think is good, and certainly there appears to be a high demand for this vaccine, which is always good from a public health perspective. But then again, looking at from a preparedness standpoint, looking at phase 2 planning, and then utilizing, again, from my perspective, utilizing all of this energy and excitement around all of this to be able to better inform the next steps of what we talk about with long-term capacity building. So that some of these building blocks, public health tools that need to be in place already, we could start having a conversation about what the next 3 to 5 years of capacity building looks like for them. I did want to talk about one other aspect of this that I think is critical, which is the strategic communication and the public affairs around the vaccine. And we've really viewed this as one of our top priorities. So we've done a couple of things, and I'll actually put it into the chat box here so that you all can pull it up. We've done a couple of things from the regional office in partnership with FEMA. Sorry, I'm multitasking here. In partnership with FEMA to, again, with every ability possible within our capacity, at least from the federal side, to be able to kind of inform our stakeholders. So we have built what's called a communicators network across all of the vaccine task forces in the region. And we have, the ability to reach out and communicate quickly with all of the public affairs officers and the vaccine task force leads, and be able to push them information from the national perspective relatively quickly. And then the other item that I think is very valuable in this tool, and I'll send the link in the chat right now, is the ability to leverage some of the work that's going on at, again, the more local, the grassroots level. So the community-based organizations and the faith-based organizations who are doing incredibly good work with some of the communities that they serve for things like translation of some of these products. So you'll see within this portal link that I sent you, that there are different tools within there that require language translation. If you're talking about Pacific Islanders, if you're talking about migrant farm workers, and some of these really, really great community-based organizations that we've come to work much more closely with during the COVID pandemic are doing great work. So this is, again, another opportunity to share that across the region and be able to leverage some of the work that some of these great organizations are doing. And so along those lines, we're also working with FEMA on looking a little bit closer at volunteer organizations during assistance to disasters, VOADs. If you don't know about VOADs, many of you probably do. We're working closely, hopefully moving forward in that long-term recovery lens to be able to have those conversations on everything from broadband. Broadband communication is a big part of what folks are talking about right now. Now, what does that mean for us? And certainly some of my colleagues on the call would probably agree that broadband is incredibly important to delivery of healthcare services, certainly in for telehealth and telemedicine, which has been increasingly useful and helpful and meaningful during this pandemic. And so broadband is not just being able to stream movies really, really well, but also being able to deliver quality healthcare to folks in some of the more rural communities and hard to reach communities in our region. So I know I'm at time, I think, Yusuf. So I will stop there. Hopefully this was able to help the conversation along a little bit. There's a lot of work that will take place moving forward, and a lot of, I think, important new conversations to have as we hopefully, again, knock on wood, move away from this high burden with the virus across our Western states, and can really now start to talk about what mitigation looks like and what hopefully recovery looks like for our region. So thank you again, Yusuf. I'm happy to take any questions from any of the folks on the call, and I'll do my best to answer them. And if I can't, I'll follow up with you, Yusuf, and get you answers to the questions. So thank you again for the opportunity.
Thank you very much, Commander Johns, and all the presenters for those great 4 presentations that we had back to back. I've also learned so much in the last 1 hour, and I hope the audience did as well. We'll now move on to the Q&A session for the last 15 minutes. We've been keeping track of all of your questions to everyone who's watching, and we have them ready to ask the panelists. So for the panelists, how this next 15 minutes will work is one by one, we'll ask you the questions that the audience has been putting in. And if you would like to answer this question, you can use the raise hand function on Zoom, and that should be under participants and then the 3 dots you see. If you would prefer to not do raise hand, you can also just send me a chat message. Either one would work. So I can just give about like a minute or so to make sure you guys are okay with that. And then we can go ahead and get started with the Q&A. And please let me know if you have any questions or any technical difficulties with that. All right, we'll go ahead and get started. I also wanted to let everyone know that we have Dr. Lena Huang with us, a pharmacy clinical coordinator from Washington Hospital. And she's also here to answer any questions relating to basic science and the pharmacy in general. So I'll hand it off to Fatima now, who's going to ask our first question. And panelists, feel free to raise your hand or send me a chat function. I'll keep a track on it on my right-hand side and then call out the order for answers.
How are vaccines stored in the pharmacy and how are they shipped out from there? That being said, how long will it take to get everyone vaccinated?
So Dr. Huang, you can go first.
Oh, sure. Well, first of all, thank you for including me and allowing me to share with you what Washington Hospital Pharmacy does. As you learned from Dr. Anwar presentation, Moderna and Pfizer vaccine are mRNA vaccine, right? And if you remember from your biology, mRNA has a very short half-life, so this integrate quite quickly. The company basically make the mRNA, encircling it with nanoparticle to kind of like protect it. And kind of like, we have to keep it at a very, very cold temperature to keep it stable. So when we received the Moderna and Pfizer vaccine, we actually received them frozen. And it's quite interesting. The company sent them in like a thermal container with dry ice and also have thermometers in there. And then from there, we will transfer them to an ultra low freezers. We have 2 freezers. We're lucky that we have 2 freezers. Not every hospital have the capability like we do. So we have Moderna vaccine that we store in 1 freezer, -20 degree. And we have another freezer to store Pfizer, -70 degree. And then from there on, we just do a lot of coordination with the front line because this vaccine has to be thawed out first, right? So Moderna is a lot easier to manage because it is stable in refrigerator for at least 30 days. So depending on the number of people scheduled to be vaccinated, then we will move X number of vials, usually like the night before, from the freezer to the refrigerator and let it thaw out in the refrigerator. And then, we coordinate with the nurses who will administer the vaccine depending on the number of patients being scheduled. We'll deliver them throughout the day. And if the vial is unpunctured, then it will be stable for 12 hours. But once it is punctured, then it's good for 6 hours. So then again, it's a lot of coordination in terms of like when and how many we deliver and how many doses each vial will deliver versus the number of patients that are actually scheduled for the day. Pfizer vaccine is a little bit more challenging because it has shorter half-life or shelf life. It's only good in the refrigerator for 5 days. Plus, it needs to be diluted. So in the pharmacy, we'll have to, take the vaccine that we need to be delivered to the front line. We have to dilute them first and then deliver them to the floor. Once it is diluted, similar to Moderna, it's only good for 6 hours. So as far as the number of people that have been vaccinated in the hospital, I think Dr. Martin had mentioned to you, we did quite well in terms of our employee, the frontline clinician, and also the frontline staff members. I think majority of us have been vaccinated. And I think you have learned from the county as far as the priority people who will be vaccinated next. I believe 75 plus, 65 plus, and then keep going from there.
Thank you, Dr. Huang. We'll move on to the next question.
So is it possible to request for a particular vaccine when it's my turn to get vaccinated?
So again, if any of the panelists would like to answer that question, you can feel free to raise your hand or send me a chat.
I didn't hear the question. Can you repeat that?
Yes. Is it possible to request for a particular vaccine when it's my turn to get vaccinated?
I'm not sure. I don't know if any. I guess if there are many doses available, then potentially depending on availability, maybe you may be able to choose.
Dr. Martin, do you have any other insight onto that from Washington Hospital?
So I didn't know quite how to raise the hand because I couldn't find it. So I just unmuted if that's okay.
Sure, that's fine.
So I'm guessing you might be able to choose because right now we have both vaccines. We have finished the Pfizer and we just have the Moderna. So you had the option for choosing in our facility. They are roughly equivalent in terms of effectiveness. The one that will be quite different will be the Johnson & Johnson when that gets done. And I'm guessing we probably will roll out through community like Lauren was talking about, like the pods. And so whether or not they get staffed or supplied for a particular vaccine may be advertised, maybe not. So I don't know if that's something that the county may release that information, or they're just going to say it's the COVID vaccine. I don't know, maybe Lauren can answer that later, or maybe you could put it in the chat and she can respond to it.
This is Lauren. Unfortunately, I do not know off the top of my head. I do believe that you might be able to ask, but I think it's going to depend on what is available that day. We have not, I don't think, traditionally been advertising a specific vaccine for our specific pods, but I would have to get back to somebody with a more formal answer on that.
Thank you, guys. Next question.
Will we see this new technology of the mRNA to cure a simple cold in the future for its vaccines? Could there be a vaccine where we could be immune from the cold?
Dr. Huang, go for it if you would like to answer that.
I didn't hear it completely. There was immune from what? Something else? Can you repeat the question?
Will we see a new technology of the mRNA to cure a simple cold in the future for its vaccines? Could there be a vaccine where we could be immune from a common cold?
That's a really good question. I don't know that they've got that technology worked on, but I guess it depends on what the response is with this. Maybe for future we could be using it, because the thing that's interesting about this is they can manufacture this so much faster. Because if you look at the current technology for the influenza vaccine, it's incubated in the egg, and that's why it takes so long. And that's why a lot of times we're sort of shuffling to try to figure out from one year to the next, what's the most common virus and how are we going to make up the vaccine? Because there's actually 3 to 4 different viruses in the influenza vaccine. So the recombinant vaccine is there's one influenza that's a recombinant vaccine, which is right now way more time consuming to manufacture. But I think the RNA, if that does look like we can do it going forward for this vaccine, may be the wave of the future, because we can manufacture it much faster and then we can adapt much better if, like, we've already seen mutations with this virus already. So that, I think, if that's your research project, I'm going to support you.
Yeah, Yusuf, on that issue, this is Matt again. There was a scientific, well, actually, it was just a published article that came out a couple of days ago, where they're looking again very closely at seasonal influenza, obviously as a really, I think, near-term goal, obviously, because it's really important. But they're also looking at HIV and Nipah virus. So Nipah virus is a bat-borne virus. Of consequence to everyone in the world, but it's kind of more geographically focused in South Asia and Southeast Asia. But it's I've investigated Nipah virus outbreaks in the past, and I would say that a vaccine would be welcomed, given how consequential those outbreaks have been. So those are the 3 that I think have been discussed recently. And again, for those of us who've worked at all in respiratory disease, a seasonal flu vaccine utilizing mRNA for all the reasons my colleague mentioned is incredibly important. Getting away from the egg-based vaccines, and my goodness, it would be a game changer, no question.
Thank you. And we can ditch the raised hand protocol. I think it would be easier if you would just like to unmute and answer. We can just go for that instead. So next question.
Any of the panelists can answer this question, but does COVID-19 affect a specific race more easily than another? If so, why?
So I would say, I think we don't really know that very well, but we do see a lot of ethnicities have less access to healthcare and may have more more additional illnesses. So for certain populations have more diabetes, have more obesity, and those two, from odd reason, those two make it almost a death sentence when a person gets COVID, has diabetes, and is overweight. Those are the patients that struggle the most, are in the hospital the longest, on the ventilators the longest, and generally are the ones that you would think it's an older population because of their immune system, but it's that. And so I think there are certain ethnicities that have those comorbidities. And so I think we do see them because of that, and because they're also underserved, and probably sometimes because of immigration and because of conflicts don't really want to access care as readily. So I think all of those factors kind of combined to making it much more severe for the underserved. So I think that's why we really want to work with the county, because this county is very progressive in making sure that we are working with the underserved groups as well as the socioeconomic that are higher level to make sure everybody gets access to this vaccine.
Thank you. Ms. Barranco?
I'd echo that. I don't think there's any scientific or medical evidence that anyone ethnicity or race would have any proclivity toward getting this vaccine, or getting the virus, or getting it more seriously. But this really is a social determinants of health situation. We have really scary disproportionate rates of COVID, specifically in Latino and Latinx communities in Alameda County. Our death rates among African Americans are frighteningly high within Alameda County. That's the data that we've seen. And we know, that a lot about our zip code determines our health. I know a lot about whether or not we're essential workers, whether or not whatever our access to healthcare is, our access to healthcare information in our language. We know that a lot of these can be barriers for people who are working to stay healthy. And so it's, we've seen also in terms of sort of economics, like overcrowding and housing, not having enough affordable housing where people can spread out and social distance. And so there are some correlations between some ethnic or racial groups within certain zip codes due to a lot of the socioeconomic and social determinants of health factors. But that is not, there's not a medical connection.
Thank you. I know we did pass 5 p.m., but there are several new questions in the Q&A. Speakers, I know we agreed to 5 p.m. at the end time, so if you do have to go, that's all right. But if you would like to stay for 10 more minutes, that would be great, and we could answer any other questions. Yeah, we can go for the next question.
Okay, if a person belongs to the phase 1C, 2, or 3, should they register now for the Alameda County vaccine notification? If not, around when should they register?
You could register at any time for the notification. Again, it's not signing up for an appointment. So I would sign up at any time, and then depending on what you put in there, that's when you'll get information on when we're making it to that phase. So I don't think it's too early to do that, but it may be a little while before you hear from us.
Thank you. Next question.
How are different medical conditions categorized in terms of the vaccine timeline? Are there any groups with conditions who should be cautious? So, for example, if a pregnant woman, chemotherapy patients, people with allergies, etc. And once again, anyone can answer this question.
So currently we're not vaccinating pregnancy. I think there are some ongoing studies on that. So it's not totally contraindicated, but it's not been approved for the vaccine. The immunocompromised are, I think Lauren probably knows better than me, I think it's in the 1C. So they are where we would definitely want to make sure that they are prioritized.
Thank you, Dr. Next question.
Hi, I wanted to direct this question at Dr. Martin, but of course, everyone else can answer. Why are 2 doses needed for a higher efficiency rate? Is it possible for 1 large dose to be used to reduce cost and time?
So that's like a super interesting question. So what they did was to study it, and with 1 dose, it did increase your response, but they did notice with the second dose, the response rate went up considerably. That being said, the AstraZeneca, which is the one that's probably, so Pfizer, Moderna are the currently ones that are FDA approved. The AstraZeneca, which is one of the ones that's being studied and released now, had some sort of a mix up in that they did a half dose and then a full dose. And they noticed that compared to a full and a full was actually a better response rate. So they're still trying to figure out exactly what to do with that. The Johnson & Johnson actually is a single dose. So I think it's just how the manufacturer decided to study it and what they were looking at in terms of response rates. So, I mean, good question. Maybe Lena can answer that a little more specifically.
I think in general, vaccine, they are based on subunit. So in this case, the subunit that is being produced is spike protein, right? So it's not the entire viral, it's just a subunit of it, which is the envelope that protect the virus. That was the vaccine producing. So any vaccine that use this subunit as a way to generate immune response, sometimes they do need a booster. And perhaps that's why they do study the second dose, just to make sure that we have, like what Dr. Martin said, that we generate enough immune response to be able to, manage the COVID-19.
Thank you, Dr. Huang and Dr. Martin. Our next audience question, I think Ms. Erickson and Ms. Bronco, I think you would be best suited to answer this. which school district do you think will open first in Alameda County? And specifically, what's your estimation for FUSD in terms of opening?
Okay, I think I can address this one, Yusuf. I didn't hear the last part of your question.
Yes, the second part was specifically, what is your estimate for FUSD in terms of reopening?
FUSD. Oh, okay, got it. So unfortunately, I can't really answer that question. I know school districts have been planning they're in constant planning and updating their plans. I think that in the next week, this is going to be a big week because, as I mentioned, the state is going to be releasing some new guidance and some new details about their Safe Schools for All plan. So I think that districts are going to be responding to the incentives if they're approved by the legislature and some of the new guidance. So we'll probably get a better sense in the next couple weeks around where districts are with this new plan. It's definitely, yeah, it's been, reopening has been very challenging for the large public districts. And I know they're really trying hard to make it happen as soon as possible. And unfortunately, we ended up with a huge surge, which made it, kind of put a halt on the reopening because of our large cases. So also hoping that our cases will stabilize a bit so that we can actually move into reopening.
Got it. Thank you, Ms. Erickson.
Sure.
I did see your chat. I think that's important info for everyone who's watching right now. We can move on to the next question.
This is a more specific question. Which phase would food bank or pantry workers fall under?
That's a great question. I would have to look into more detail. There is a state list of essential workers, and I know that they've profiled food and agriculture, and I'm stalling while I try to look for it, but I can put that in the chat where it gets really granular around who is considered the definition of each group. And we know that phase 1B tier 1 has food and agriculture in it for sure. If not, phase 1C has governmental ops and community services in it. So it would be in one of those two.
Thank you, Ms. Bronco. Next question.
So if someone is expected to care for a patient who just came home from after a hospitalization, can that person be first in line for vaccination?
Sorry, what was that question again? Sorry
yeah. If someone is expected to care for a patient who just came home after a hospitalization, can that person be first in line for vaccination?
I don't have the answer to that. I know that folks who are serving as home health care workers and home health aides are coming up really shortly but I couldn't tell you off the top of my head if somebody who's doing it in more of an informal way and isn't registered through an agency. I do not know that priority, but I will look into it. It's a great question.
Thank you. Next question.
So this one's more directed at Dr. Martin, but anybody can answer that know the answer. So although both Moderna and Pfizer vaccines are mRNA vaccines, why do they have such a huge temperature difference for storage?
I actually don't know that. Maybe Lena knows that answer.
If I have to guess, it's because they have different nanoparticle that encircle the mRNA, and they also have different excipient to kind of like stabilize it. And because of that, they have two different temperature storage.
Thank you, Dr. Hong and Dr. Martin. Next question.
Any of the panelists can answer this question. Do I need the vaccine if I already had COVID-19?
So we would all say yes, they definitely do, because we think that, just because you've had it doesn't mean that you might not get it again. Right now, current recommendations from CDC is a 90-day window. So if a person has it today and recovers, usually we recommend a 90-day window before they start the vaccine series.
Thanks, Dr. Martin. Next question.
If you had a choice between the Moderna or the Pfizer vaccine, which one would you recommend?
Maybe Lena wants to do that. She did do a study on all of the AstraZeneca, the Johnson & Johnson, and all four. So I'll defer to Lena. It's a very tricky question because they're all made a little bit differently and we all think they're equally effective. So do not take this answer to being that you are not going to get a vaccine because you don't have the one that might do something different. So I think between the AstraZeneca, they still have to worry to figure out what the dosing schedule is going to be. Between the Moderna and the Pfizer, I think they're roughly equal. I would say either one of those are equally protective and not a thing. Supposedly the Moderna has a little less side effects, but I think that's negligible. I think, the other thing is, as we see more and more people getting the vaccine, whether you're somebody who's, 65 plus, or you're one of our frontline workers that's 25 years old, those immune systems are very different and respond very differently. So I think we have a lot to learn. So I would say whatever vaccine they're giving, sign up. So I got mine. I got all 2 doses of mine. So we get little stickers to say that you got your vaccine. So I would say wherever you can get it, sign up. And I think, take what you can get. I think they're equally important. But I mean, Lena may have another comment or something.
No. There are nuances in the scientific data, but I think overall both have equal efficacy. So like Dr. Martin was saying that, you should get whichever happened to be available, either Pfizer or Moderna. It's actually a quite neat new technology to deliver vaccine via mRNA. So, and both of them are pretty safe. They are safe and efficacious. So whichever, I would say.
Thank you. And we can have our final question now. I know we're reaching 5:15. So we'll have our last question and then we'll do some closing remarks.
Yeah, so if a person is given a Pfizer as a first dose, are they guaranteed to receive a Pfizer second dose? That is, are they given a slot to receive their second dose right after they receive the first dose?
So generally at the hospital where we're doing it, and maybe Lauren can speak to this if she's still on, we're recommending that you stay with the manufacturer that you got, so not to mix up. I know there's some studies right now in England where they are doing mix up just because they want to roll it out as fast as possible, but we just don't know what the consequences of that are. So the manufacturer's recommendations and CDC is basically to stay with the same manufacturer and stay within the guidelines. So the Moderna is actually dosed at 4 weeks, and I think the Pfizer is at 3 weeks. And there's like a 3-day shorter window for each of those if you can't get exactly the same day. So I think one of the questions they had talked about that Lauren mentioned was going to be the making sure that if somebody comes in to get the vaccine, that they then know they need to come back in for the second one. How do we track that? I mean, the hospital, we're obviously tracking that because we're all employees and we all have, badges and emails and everything like that. So we signed up for the second dose as soon as we got the first dose.
Yep, I don't have too much to add to that other than, there's a time schedule and you'll get information on what that time window is. We definitely have, there's a state system called CARE that has a record of everyone who's gotten the vaccine and when. And so ideally when you come in for the vaccine, there's an easy way to contact you for when it's the next turn. And I think at the state level, I think the point was just mentioned by Dr. Martin, I think they're talking about whether or not you can mix vaccines, but as far as I know, we're not mixing the two. If you got Pfizer, you still got Pfizer, as far as I know.
All right, thank you so much. That will conclude our Q&A session and our webinar. Panelists, thank you so much for coming on and giving us 1.5 to 2 hours of your time today. We really appreciate it, and we hope the audience learned a lot about the COVID-19 vaccine. I'm going to quickly hand it off to Hirsch, who's going to talk for 1 minute about a feedback form, and then I'll close off the webinar.
Yeah, so once again, thank you everyone for attending the webinar. I'm sending a link to a feedback form in the chat. So if you guys can all just access that. We just want to quickly know how you guys liked what you guys liked about the webinar and if there's anything we could improve. And also you guys can look at this webinar later on YouTube. It'll be there right after we end the live stream. And I've sent the link for that too on the chat. So spread this to your friends, family, whoever. Thank you.
Thanks, Hirsch. And while you guys are looking at the feedback form, I'll just talk a little bit more about where you can learn more about YEPC in the future. You can find us on Facebook and Instagram at Youth Emergency Preparedness Council. That's where we update all of our live events, and we would love for more members to join us and help expand this mission in our organization. And speakers, if you would like me to connect you with any of the other speakers, please let me know and I can make that happen. And other than that, audience members, we hope you had a great time, and thank you so much for tuning in today on January 13th.